A very good morning to everyone. Thank you for joining Medflix 2021 today from the comforts of your home or practice. My name is Wong Jyi Lin and I will be the moderator for today's sections. So the topic that we will be discussing now is Reimaging Asthma Care, Triple Checkpoints, Triple Assurance. But before we proceed, we have some few housekeeping details to go through with you all. So this live section today will work based on a webinar format. Our speaker will be delivering his talk, followed by a Q&A section. So if you look at the right of your screen, you can see there's a button which you can click on and post your questions. And I will direct these questions to our speaker for discussion later on. Without any further ado, let me introduce our speaker today, which is Dr. Wong Jyi Lin. Dr. Wong is a consultant respiratory physician at Borneo Medical Center, Kuching, Sarawak, and he graduated with MBBS from University of Melbourne in year 2000. He obtained his membership of the Royal College of Physicians, UK and London, and later he pursued his Master of Medicine in Singapore in year 2006. He is also currently the member of Malaysia Medical Association and Malaysia Thoracic Society. Dr. Wong had served as medical advisor in government hospital for about 15 years. He is extensively involved in respiratory subspecialty training in Malaysia, and now he is serving as consultant respiratory physician for more than a decade since year 2009. So let's us give a warm welcome to Dr. Wong. Welcome, Dr. Wong.
Hello, Willing. Hello, everyone.
Hi. Yeah, so with reference to today's topics, right, I believe that asthma has been a very familiar term to most of us. But what exactly is asthma? Can doctor briefly tell us what are the changes in terms of asthma understanding in previous decades?
Right. Okay. Right. Before we begin, let me just put some disclosure. Basically, I do receive honorarium from the DKH for doing this talk, and also some of the slides are provided by DKH. Okay. So that's the disclosure. Well, asthma is actually a disease that has been long-standing. I mean, more than 2000 before Christ, already people are describing whispering sounds in the airways, and in the ancient Egyptian, also actually ancient Chinese. So our understanding of asthma actually started in 19,000s when Osler, the guy who father of medicine, actually described inflammation in the airways. He is probably the first person who described inflammation in the airways. Initially, the asthma is always about bronchospasm, wheezing, the symptoms, and the treatment between 19,000s and also 1960. Basically, the treatments are mainly concentrating on bronchospasm. So usage of anticholinergics, aminophylline as bronchodilators. As our understanding of asthma evolved, we start to realize that inflammation, and that's when the usage of steroids started coming in the 1960s. In 1980s, the long-acting beta agonists started to come out, so people now go back. Instead of inflammation, now concentrating again on bronchodilation, how to better bronchodilate. Only in the last 10 years, our understanding of asthma has evolved in such a way that we now understand the inflammation much better. So now we've targeted treatments for asthma, not just steroid, but also targeted treatment. So basically, asthma is a disease that, as we understand now, causes bronchospasm. The symptoms are mainly due to bronchospasm, and the bronchospasm are usually associated with inflammation of the airways to certain allergens. So that's our understanding of asthma up to now at the moment. Yeah. Now the asthma symptoms usually they have classical symptoms. They have wheezing, they have breathlessness, chest tightness, and all of these are usually due to bronchospasm and inflammation.
Okay, thank you, doctor, for your clear explanation. So we come to know that asthma is a respiratory disorder which not only bronchospasm, but it also involves inflammations that associated with the burden symptoms like wheezing, shortness of breath, and tight chest, which can significantly impact a person's quality of life. Yeah. So, doctor, how about the prevalence of asthma in worldwide and also in Malaysia now? Are there any major changes in the prevalence of asthma in the past few decades?
All right, let me show you some slides. Well, this is the number of asthma patients globally at the moment, 235 million. Now, we all worry about COVID. Yeah, we talk about COVID. Now, I think COVID is about 135 million. So, double the number of COVID patients at the moment globally. So that is just to put into the context the number of asthma patients globally. Now, each year there is more than 400,000 deaths. Like in 2015, with the data of 383,000 deaths just by asthma alone. Yeah. And the worrying thing, of course, is asthma is a disease that is increasing. So if you look at the slides that I have here, between 1982 to 2002, that will be 20, 30 years down the line, you can see that the prevalence of asthma is now increasing in trend. And this is probably due to the environment and the lifestyle that we have, the presence of pollution, the less infection, and also the prevalence of smoking. All this probably caused the increase in the asthma trend.
So
now I'm just going to talk about Malaysia. Yeah, if you walk on the streets, out of the 100 Malaysian populations, probably 4 or 5 of them are actually suffering from asthma.
Okay, thank you, doctor, for the information. So since this asthma is quite a common disorder nowadays, so like what will be the key challenges that you may face in managing asthma?
Well, let me show you a little bit more data. Well, what are the challenges? We know that asthma is a disease that causes mortality and morbidity. But if you look at the number of patients who actually seeing doctors that are being followed up in clinics and hospitals, only about 1/3 of them actually are seeing the doctors. The rest of them are in the community and they're probably not getting the treatment. They're not seeing doctors. Yeah, you may think that that's all right, but if you look at it, 2/3 of them actually has problems. They have symptoms. They end up with what we call asthma attacks. Yeah? We can see that the patient with heart attacks, they're so worried about heart attacks, they've seen doctors. The asthma attacks, 2/3 of our patients suffer from asthma attacks, and yet only 1/3 of them are actually going to see the doctors. So that's one of the problems that we have. One of the challenges that we have is to get the patients to go and see doctors and get the treatment.
That's actually an unfortunate event that's happening now. As we can see, the following rate is very poor.
Yeah.
So what would doctors suggest in order to prevent further exacerbation from happening in the future?
Well, first of all, of course, to our audience who are mainly doctors and GPs, one of the things is to increase the awareness to our patients that they do suffer from asthma and they need follow-up. Now, once they recognize that, when they come to us as GPs and doctors in the hospital, then we have to manage them. And together with the topic today is a checkpoint. So I actually put 3 things that I think are important in the management of asthma patients, which is using the correct medication on the correct patient and using the correct device. Yeah.
So talking about one of these 3 checkpoints, so actually what are the medications that are available now, and then the things that we need to consider in choosing the right medications for our patients?
Yeah, well, as you can see, correct medication, let me just, okay, so we're going to first of all talk about correct medication. This is the asthma medication that's available. There is much more than this, okay? I'm just getting some of it. So you can see there's millions of them, but then they can be generalized, divided into 2 types, which is what we call a rescuer. So you have the short-acting beta agonist and the rapid-acting, ultra-long beta agonists, who both these act fast and therefore they act as a rescuer. And also you have the controllers. So these are the things that control the disease. Now, what are the difference between these 2? A rescuer provides you with the symptom relief. So it gives you the quick relief, it relaxes your airway muscles, it bronchodilate, okay? Whereas a controller provides you the long-term control. It reduces the inflammation, it delays action, and it prevents asthma attacks. Okay. Now, as a patient, most of our patients, they will know about Respiratory. Why? Because it provides them with a quick relief. So a lot of patients know about the Respiratory or the bronchodilators. So if you look at these slides, actually, a lot of patients are using the drugs. They are using the bronchodilators. They use a lot because when they have symptoms, they will go and see doctor, they will go to the pharmacist, they will get the bronchodilators. But if they just use the Respiratory, I just go back a slide. If they just use the Respiratory and they are not using the controller, you can see the problem. When you overuse your Respiratory or the beta agonist or the bronchodilators, actually you have increased asthma death rate. Okay, so our patients like to use bronchodilators because it gives them the symptomatic relief. Unfortunately, if they just use relievers without using a controller, they actually have increased asthma death. Okay, so that is a very increased usage of Respiratory is actually a very strong warning sign that your patients are not controlling their disease. If they are controlling their disease, then they actually do not need to use all these Respiratories. So asthma medication, there are two types, the Respiratories and the controllers. And the patients tend to overuse Respiratories and not using their controllers. Yeah, so that's one of the problems we face when we treat patients. Yeah. Okay. So I'm going to proceed. So how do you match? Yeah. What kind of patient needs what kind of medicine? Yeah. So basically, what we need to do in the next step is once you recognize that patient needs medication, you need to choose the correct patient. Okay. Now, what do I mean by correct patient? First of all, when the patient comes to you with the symptoms of asthma, in order to treat the asthma, first of all, of course, you need to confirm the diagnosis. You need to make sure that you get the right diagnosis that the patient is actually suffering from asthma. If your patient is not suffering from asthma, obviously you're not using the correct medicine on the correct patient. Yeah? Then the next thing you need to consider is how bad is their symptoms. If they have very bad symptoms, you give them a controller without any rescue, then obviously they are not going to get the symptom relief that they want, and they're not going to come back to you. They're going to go to someone else. Right? Then you have to consider comorbidities. Comorbidities like some patients may have runny nose, reflux, and this will make their symptoms much more difficult to control. So once you decide the patient needs medicine, you need to choose your patient. You need to make sure that you are treating the right patient with the right medicine. Yeah. So what I'm trying to say is not one medicine fit all patients. Different patients need different medicines, and that is the skill and that is the art of treating asthma. All right. I'm going to continue. I'm just going to show you this slide. Yeah. In fact, not just different patients are different. Even one patient at different times they are different. For example, this one. When the patient is very well, if you can see, this is the compliance, whether they are using their medication or not. When they are feeling well, basically your compliance your compliance are not as good. When your patient is not feeling well during worsening, you can see that their compliance increase. So when the patient is unwell, of course they will want to use medicine. When the patient is well, they don't want to use medicine. So one person at different times will behave differently. Michael Partridge is the person who concentrate a lot on patients' perspective. So if you look at this study by Michael Partridge, I'm just going to go back. Yeah, if you look at the study by Michael Partridge, you will see that the patients have each patient has many different needs. Some of them want to have immediate relief. Some of them want to use it when necessary. Some of them are confident to know that their asthma well. Some of them are not. So different patients have different needs. Okay, so that's what makes management of asthma a bit more difficult. I'm just going to go to the next slide and I'm going to show you, okay, because of understanding that the patient want to use medicine differently at different times. When they're unwell, they want to use more. When they're well, they don't want to use more. So there's this concept of SMART come along. So I think most of you would heard of the SMART therapy. So basically the idea is you will have some dose of a controller as a maintenance, and when you need it, you will use a rescue. So the blue colors are the rescue and the red is the maintenance. So this is the traditional way of thinking about asthma. You use a maintenance controller, and when you need, you use rescue. So the new idea that come out is actually you have a maintenance, but at the same time, instead of using a rescue, you will allow the patient to adjust their controllers. Okay, because remember I talked about the disease. It's the controller that is important in control the asthma symptoms. It's the asthma inflammation. So if you just use symptomatic relief, then you cannot control the inflammation. So the idea is every time the patient feels like they need the medicine, instead of just getting the bronchodilators or the rescuers, they are also getting extra doses of controller. And that is what we call by SMART, using a controller and also as rescue within one drug. So that is what we call SMART. So it is a very smart move because it allows you to have lower maintenance dose. And when the patient feel like they need to use medicine, they use medicine, they get both a rescuer as well as a controller. So in that way, they are getting extra controller into themselves. They are not overusing just the rescuer. So it's a very smart idea. Okay. GINA recognized that. The GINA is basically the Bible of asthma management, and GINA in 2019 recognized that patients want to use medicine when they are feeling unwell. And this is the time, this is the opportunity for us to give them more controllers when they're unwell. So they recognize that. So you can look at 2019. Yeah? Before that, before 2019, in step 1, there's always just a low dose inhaled corticosteroid, and they will use rescuers when needed. Now in 2019, GINA has changed it. GINA has said that instead of just using the rescuer, now you're going to use a rescue plus a steroid as a initial therapy. So instead of patient using Ventolin when they're having attack, rather than giving them just Ventolin, now you are going to give them a device that contains both a steroid and also a reliever. So this is changed in step 1. It's added into step 1. Last time used to be step 1 is just a Ventolin, a rescuer. Okay, and in fact you can see that in step 1, step 2, step 3, step 4, step 5, every time you need a reliever, the preferred reliever is actually a reliever that contains inhaled corticosteroid or a controller. Yeah. So that is the difference between what we are changing now, that we are adding controllers to our patients when they take extra medications. Yeah? Is that okay, really? You can understand the part?
Yeah, it's well explained, doctor.
All right, okay, so we'll go on. In 2010, GINA now highlight further the importance of inhaled corticosteroids. So you can see, they now say that low-dose inhaled corticosteroid should be started in step 1 and step 2. Now the inhaled corticosteroid is actually, inhaled corticosteroid with a formoterol or a rescuer is actually the preferred reliever rather than just Ventolin alone. Yeah. So GINA start to emphasize again and again the importance of inhaled corticosteroid, especially giving them extra inhaled corticosteroids when the patient is having attack. When they want to use medication, they get extra inhaled corticosteroid. Yeah. So this is all good. This is all clever. This is good. But again, I want to come back to this point. Not one medicine fit all patients. Not every single patient you can do that. Not every patient you can ask them to use a SMART therapy. Why is that? Let me just explain to you. Okay, now this is SMART therapy. If you look at SMART therapy, one of the problems with SMART therapy that people worry about is because you are not using your patients when they are well, they are not using a lot of maintenance. So one of the problem is whether using smart therapy can actually control inflammation. And this is one of the famous paper, one of the key papers by Harvard, actually showing that your inflammation is actually not controlled as well by using smart therapy. So rather than giving you a patient a controller or a dose of a baseline steroid that is good enough, what the smart do is letting the patient use less medication when they're well and use more when they're unwell. So one of the problem is when you're doing that, you're actually using less dose of inhaled corticosteroid. So if you can look at this, instead of using a mean of 1,600 microgram of steroid, if you use smart, you're actually using only 600 microgram of steroid. So you're using much less dose of steroids in general. So one of the problem is if you're using less dose of steroid, then the problem is you are not treating the inflammation well. And this is what Harvard was saying, that look, if you use smart, your inflammations in the airways, be it the sputum or the endoluminal biopsy, your eosinophils are actually higher because you are using less dose of steroid if you're using smart. Okay, so smart works for a lot of people, but smart may not work for people who have very high inflammation because you are using less dose of steroid. Okay, and that is why I come to the key of today's one of the key message that I will bring over to our audience today is our understanding of asthma. Just now, when you asked me what is new in asthma, how do we understand asthma now? One of the key changes in our understanding asthma is this new norm in asthma management. Basically, you need to now target different patients with different methods. Okay, you need to what we call phenotype or endotype of patient. What do I mean by that? Well, I'm going to explain briefly because most of our audience are doctors. So I'm going to briefly explain this. So basically, what you need to know is I'm going to skip to these two slides because they are more a bit more. Basically, I put these two slides just to show that our understanding of asthma is now incredible. We have all this IL, interview king, the TNF. There's so many things we understand, but basically, I just want to bring you to this slide, okay, to explain what I mean. So basically, you have asthma. When you have a patient who have asthma, those could be the patient that have very high inflammation. So you can see the patients down there. Eosinophilic inflammation is very high. So high inflammation, but no symptoms. You could have patients who have a lot of symptoms are here, but there is no inflammation. So the y-axis is actually the symptom, x-axis is the inflammation. So you have a group of patients within this box that who have low inflammation, low symptom, high inflammation, high symptom. But you also have a group of patients who's outside the box who have high inflammation but no symptom. So they have a lot of inflammation but they don't complain. There's other patients who complains a lot. I cough, I wheeze, but they have no inflammation. Okay, so that's what I mean by different patients are different. You have patients who have inflammation with symptoms concomitantly. You have different. So that's why it becomes very different. It becomes very important to identify which one of the patients. What do I mean by that? Okay, I'm just going to show you this slide. Basically, Th2 response means eosinophilic inflammation. Okay, now if you look at patients who have Th2 response, what happens when you give them steroid? Okay, the red color, you can see this where my mouse is, you can see the red line, those are the high eosinophilic or Th2 response. If you give them steroid, cortisol, you can see their FEV1 or their lung function actually improve dramatically compared to the ones who doesn't have eosinophil. Okay, so the good example would be if I have a patient who come in who complains a lot, okay, who is going to use a lot of rescue, okay, but if he doesn't have eosinophilic inflammation, then giving the patient high doses of steroid is not going to help with his symptoms. You get what I mean? Okay, because the patient even though he have a lot of symptoms, he doesn't have a lot of eosinophilic inflammation. So in this kind of patient, if you give them high doses of steroid, you bend them with steroid, it's not going to work because they doesn't have the inflammation. Compared to another patient who come in, okay, he will have symptoms, he have high inflammation. These are the group of patients you want to make sure they get good dose of steroid, because if they get good dose of steroid, their symptoms are going to come down. Okay. Now then there's the other group. Think about from the other way. If you have patients who have very little inflammation but have a lot of symptoms, now these are the patients that you don't want to give them too much steroid, like I said. These are the patients who will be suitable for what we call smart therapy. So every time they feel they have attacked, when they have symptoms, they will use extra doses of steroid. Other times when they are well, they don't use that much steroid. That will reduce their steroid dose. And because they don't have much of eosinophilic inflammation, they will be all right. Yeah? So this is what I mean by different patients behave differently. You need to identify who is the correct patient to give what kind of medicine. Yeah. So you will say, well, you are a specialist. You have all these drugs that you can test for, your blood that you can take. You can take IL-5, IL-4, IL-3. So we don't have that in our clinic. What can I do? Well, this is what you can. I just show you this study. Basically, it's actually a very simple test that you can do. You can do a blood eosinophil. I think most of our GPs in the clinic can order blood, and you just do a full blood count with eosinophil count. If you have high eosinophils, then these are the patients suggested they could have high Th2. And these are the patients who you might want to use more steroids and avoid using smart therapy. Yeah, you want to use a fixed dose steroid. Make sure that they have good enough steroid. Yeah, those that doesn't have high eosinophil, you might consider smart therapy if they have symptoms. So this is what I mean by different patients behave differently. You use different medicine for different patients. Yeah. Okay, so choose the correct drug for the correct patient by identifying suitable phenotype and endotype. These, at the moment, are the main understanding of asthma treatment, and that's what I want to bring over. Okay.
Okay, doctor. So it will depend on the patient's severity, like their symptoms, inflammation. So some of the patient may not suit the smart therapy. So the choice of asthma medication will be different among patients now.
That's right. Yeah.
So doctor, how about the use of inhaler? Like are there many types of the inhaler available in the market now? Because it will be the major methods that help to deliver the medication to the patients, right?
Yes. Well, one of the management of problem with management of asthma compared to other diseases is a device. Yeah. Management of diabetes, well, I guess you have insulin, but most of them are tablets. All you need to do, take out one tablet, put it into your mouth, swallow it. It's not so hard, right? But the problem with asthma is device. You don't swallow your tablets. You have to inhale your tablets. And that makes things difficult when you need to coordinate and you need to make sure that the whatever drug that you're using is delivered into the lung. Okay, so that's one of the problems with management of asthma. All the other diseases, you probably pop tablet in, very simple, but inhaler is a problem. Why? Okay, well, first of all, there's so many types of inhaler. So if you look at it, I kind of group it into three, since we are on the topic of three. So I put it into three. Okay, you have the dry powder, you have the traditional metered dose inhaler, and then you have the newer ones like soft mist inhaler. So there's so many types of inhaler. So it's not like a tablet that you just put into the mouth and swallow. You can use a dry powder, you can use an MDI, and each one of them are different. A middle dose inhaler basically started, those are the earliest in 1955. Yeah. So they just deliver the exact amount of medication in a mist on a water vapor that you inhale the mist into your lung. Okay. The problem with metered dose inhaler is, well, you need coordination. You want to make sure that when you press and the mist come out or the vapor come out, you are inhaled into the lung instead of dispersing into the air, instead of it going to the mouth. So hand coordination are very important in metered dose inhaler. And we have problem with that. And that's why there are the newer generation, which is called the dry powder inhaler. Now, dry powder inhalers are different from middle tone inhalers because you don't need much of coordination. All you need to do is press, inhale. That's it. You can press and wait, then inhale later. You don't have to press at the same time you need to inhale. Okay? So it delivered the medication to the lung in the form of dry powder. Genius. When it come out, everybody love it. But then there is a problem. Okay? Well, because why? First of all, because different inhalers different dry powder inhaler needs different strength. You can't tell whether the medicine get into your lung or not. Yeah? And the other thing is, of course, is inhalers. Most of the dry powder inhalers, they are coupled to a glucose or coupled to a sucrose particle. And if you want to get the drug into your lung, you really need to have a very strong inhalation in order for the drug to get in. Okay, so when dry powder first come out, everybody love it. It's easy to use, but the problem is a lot of patients cannot generate enough flow to inhale the medication. So that's why you have the newer generation like soft mist inhaler, where it can deliver the drugs, not much of a coordination needed, and it can get into your lung easier. You don't need to suck blood. Okay, so today I'm just going to concentrate mainly on devices, a dry powder inhaler. Why I want to concentrate on dry powder inhaler? Because we're going to talk about a drug that uses a dry powder. But before I started there, I just want to show you the problem if you're not using the device correctly. Yeah, remember I said drugs put into the mouth, swallow, easy. But if you're not using it correctly with a device or an inhaler, basically if you don't use it correctly, you just look at it, you have increased risk of hospitalization, increased risk of emergency room, which is not surprising because you are not getting the drug into your target organ, which is the lung. Yeah? So I'm concentrating on dry powder inhaler. I'm just going to show you why dry powder inhaler is a problem. Well, it's a problem because, like I said, dry powder inhaler needs the strength of inspiration by the patient. Patient need to generate enough force to inhale the drugs into the lung. That is the major problem with dry powder inhaler. There's many types of dry powder inhaler, and all of them have the same problem. You need a certain amount of inspirational flow to get the drug into the lung. Okay. So dry powder inhaler relies on the strength of inhalation. And patients who are very short of breath or very weak, you can imagine you ask them to, it's not possible. They can't even breathe. Needless to say, they're going to inhale strongly. So that is the problem with a dry powder inhaler. Yeah. Okay. So another problem with dry powder inhaler is, of course, the device on airflow resistance. So if you have a very high device resistance, you will need to generate a higher flow rate. Yeah, you need to generate a higher flow rate. So device that have very, very high resistance, you can see the frequency of critical errors increase. So things like handyhaler and turbohaler, they have a much higher device resistance, and therefore they need a higher strength to inhale, and patients tend to make critical error because of that. Okay, so device, there's many types and they have their problems as well. Okay.
Okay. So since like the effectiveness of the asthma treatment will be affected by what the device that we will choose, and also like whether the patient can use it correctly or not. So will there be any benefits, right, if we are using a very simple device for the asthma patient?
Okay, I think we come to the, I think you're asking the key to this today's talk, which I'm going to show you now. Okay, basically we are talking about flue duct inhaler. Okay, I'm going to talk about this drug because that's one of the purpose of this talk is to introduce this drug to our audience, to let them know about the availability of this drug. Okay, flue duct, if you can see, it is an inhaler that similar device, similar to how should I say, similar to something like Breezhaler. Okay, you can see the internal device resistance is not that high. Yeah, so basically how you use it is you just open it up, put in a tablet, close it, puncture the two holes, and then you ask your patient to suck. Yeah, I think we have a slide to show how to use it, isn't it? Okay, I'm just going to show this video about 2 minutes. I'm going to run it now, and then we see whether I can run this. Okay, we're just going to show you how this device works. Yeah.
Pull off the cap. Hold the base of the inhaler firmly and turn the mouthpiece in the direction of the arrow to open. Take one of today's capsules. Place it in the capsule-shaped compartment in the base of the inhaler. It is important that you remove the capsule from the pack only just before you use it. Twist the mouthpiece to the closed position until it clicks. Keeping the inhaler upright, firmly squeeze the two buttons once only. This will pierce the capsule. Release the buttons. Although the capsule is now pierced, the powder will not be released until you inhale it. Please sit upright and breathe out fully, but not into the inhaler. Place the mouthpiece in your mouth and tilt your head slightly backwards. Close your lips around the mouthpiece and inhale as rapidly and as deeply as you can, where a whirring sound indicates correct inhalation. As you breathe in, you will inhale the medicine into your lungs. After inhaling, hold your breath for 5 to 10 seconds. Thereafter, breathe out slowly, but not into the inhaler. Then remove the empty capsule, which also verifies successful inhalation. Thereafter, please close the inhaler with the cap.
We go on. So personally, I use quite a lot of Full Duct inhaler. The reason why I like to use it because that is the triple checkpoint. Another triple checkpoint that we're talking about. How do your patient know that they are getting the? Remember, I was talking about dry powder inhaler. One of the problem is patients don't know whether they are generating enough force to suck in the particle or not. And I find this device is useful in the sense that there's triple checkpoint. You can use 3 checkpoints to see whether you are sucking the drug or not. One is the sound. When your patient suck in, you can hear the rolling sound. You can hear it, and then you know, okay, he's getting the drug. The flow is good enough to generate enough flow to get the powder in. Then visual, like I say, when you take out the tablet first, you can see the powder inside. Once you finish, you take it out, you can see that the powder has now disappeared. So then you know the powder has been inhaled. And of course the taste, your patient will probably tell you that they do feel a little bit of sweetness in their mouth. That's not the best way because that means part of it is deposited on the mouth, that's why they can feel it. But at least then they will have some idea that yes, something is getting into their lungs. Okay, so that's why this drug triple checkpoints. When you educate your patient on how to use it, these are 3 of the things that you ask them to check and make sure that they are getting the drugs into their thing. So check your device, check. You can demonstrate to them, and then remember the checklist. Now for the dry powder inhaler, always I think the key is make sure they have generate enough flow rate. I don't know whether the GPs have it or not, but in our clinics we do have in-check down. There's one of the devices that we can see whether the patient can generate enough flow rate. So for Full Duct, you're probably all right because you can hear it, and when you take it out, you can see the powder disappearing. So probably you have that. You don't need an in-check down. But so that's why I find this product quite useful. Okay. I think we need to stress at this stage that it is important because, like I say, asthma is unique. Respiratory disease is unique in the sense that the drugs that we use are delivered not through the gastrointestinal. So it's not as easy as popping a tablet into your mouth. So that's why make sure your patient use the correct technique is very important. Inhaler is a very important part of management of asthma. Yeah. Okay. So in summary, triple checkpoint. Okay. What are the triple checkpoints? Well, you make sure that you are giving the right medication to the right patient, and you must use the right device. Another triple checkpoint is if you're using flu duct deal, make sure that your patient can hear the sound, can see that the powders has been removed, and also can taste it. So these are the triple checkpoints of management of asthma. Okay. I think that will be my last slide. So, Lin, I'm happy to answer any question if there's any question or any concern.
Go.
Hi, thank you very much, Dr. Wong, for such a wonderful and informative talk. So just a kind reminder to all the audience, if you haven't checked in for this section, please remember to do so by clicking the check-in button on your laptop, as you can see, so that we can capture your attendance for the CPD point submission. So now we will start our Q&A section. If you have any questions, please feel free to enter your questions under the Ask Question box at the right of your screen, and Dr. Wong will be more than happy to answer them. Okay. Yeah. So let's start with the first question from the audience. Okay. So the first question for Dr. Wong is like, what is the latest treatment for adults that having asthma?
The latest treatment, I guess, GINA is always our Bible for asthma treatment. So I put out GINA 2019, but 2020 is about the same. So basically, you can see there is various treatment options available, and I won't go through all of them, but you can have a look at the GINA latest guideline. Yeah.
Okay. So the next question is because now we are knowing that COVID-19 is like affecting our daily life. So is there actually any relationship between COVID-19 and also asthma, or maybe COPD?
Well, very difficult question. Well, okay. Well, I mean, the most obvious would be the use of nebulizer in asthma treatment at this stage. Obviously, the nebulizer is a aerosol generating procedure, and therefore usage of nebulizer should be very careful. The Malaysia Thoracic Society had come out with various guidelines in terms of replacement for nebulizer. So there will be the usage of nebulizer in asthma. Personally, I must confess, I don't see many of my asthma patients run into trouble with COVID-19. I must say, and I think I'm not the only one who observed, because I've read it, that in fact asthma patients, when they come with COVID-19, they are not too bad. And one of the postulated hypotheses will be the usage of steroid in this group of patients, because one of the treatment for COVID-19 is actually steroid. And these patients, asthma patients, is already on inhaled corticosteroid. But basically what I'm trying to say is, if you're worried about COVID-19 in your patient, the key is to ask your patient to continue usage of their controller, get their asthma well controlled. If their asthma is well controlled, hopefully they don't run into trouble with COVID. Of course, they need to wear their mask, they need to do their social distancing. Yeah.
Sure. So the next question is about use of steroid as well. So because steroid, when they are using by the inhaler mode, it will increase the risk of getting the glaucoma, what we call it as steroid-induced glaucoma. So in this patient, right, what would be the suitable controller for this type of patients?
Okay. If you can see the screen, the share screen, it's basically GINA have options for inhaled corticosteroid, especially in the ones that were mild to moderate asthma. They may, of course, as a respiratory physician, asthma is the key to, steroid is the key for asthma treatment. If I can, I will use steroid. We will try to use the lowest dose available, and that's where the individualization and phenotype, endotype of your patient is very important, that you try to address the inflammation using the lowest dose of steroid. If you really cannot use steroid because fear of side effect from steroids, Then you have the option of a leukotriene receptor antagonist. You do have other choices, but basically inhaled corticosteroid is still the key. The various steroids have various efficacy. We will try to use the lowest possible strength of steroid in patients that needs them. Yeah.
Okay. And then we also received another question saying that this audience is working in KK, so they often face like patients like pregnant ladies that have a childhood asthma, and then their last exacerbation is during adolescent period. So do we need to restart them with both maintenance and rescue medication, or they only can start after the exacerbation happens?
Yeah, well, I guess, again, individual patients have individual wishes. Some patients are worried about side effects of steroid unnecessarily, I must say, but some patients are worried about it. They are very reluctant to use steroid. There's other patients who are worried, well, especially doctors, we worry about exacerbation. If there is an exacerbation, obviously, the risk to the patient, the risk to the baby. And we know as your pregnancy advances, as you put pressure on your diaphragm, you do get into trouble with asthma. So once you have an exacerbation, then you start the treatment, it could be too late. Especially if you're not on steroids and your exacerbation becomes very bad, you have hypoxia from it. So again, you have to individualize. We have to talk to the patient that the risk of having an exacerbation during pregnancy is higher. You really need to start the controller to try to prevent an exacerbation. The risk of steroid or the risk of controllers on pregnancy has been well studied. We have enough data to tell that they are safe, especially if you use lower dose, you don't use the too high dose, keep them under control. So yes, it is me. If the patient is pregnant, I always put them on inhaled corticosteroids. I'm trying to tell them that I'm just trying to prevent an exacerbation. You may not get an exacerbation, but if there is an exacerbation, then there's detrimental, there's a bad effect on the children and also on the pregnancy. And if you look at the slide that I showed in Genome 2019, even the mild asthma in the step 1, inhaled corticosteroid is now controller is recommended. So yes, so if in pregnancy, I would certainly consider controller. I think the key is to address their fear about the side effect of the medication.
Okay. And another question is regarding the use of steroid in elderly patients. So what is doctor's opinion on using high dose or frequency of the steroid? Is it safe on them?
Yep. Again, it's about side effect of the medication. We just have to balance. And the best way to balance the risk and benefit of steroid usage is basically to use the lowest dose of steroid to try to control the symptoms as well as inflammation. And this is where all the phenotype and endotype come in. How to measure inflammation, how to measure their lung function, and how to use the lowest dose to keep them in the best condition they can. Yeah.
Okay. And another question is regarding the SMART therapy. So what will be doctor's opinion between Foster and the Symbicort therapy?
Oh, well, I'm not trying to sell any medication. I don't think any of them pay me money to do it. So I'm going to say it's the same. But I can tell you what the argument about Foster is. They are fine particles. So the steroid dose that they need may be lower than Symbicort. But Symbicort has robust data on SMART, whereas Foster are relatively new medication. So I think both of them, again, individualized. If your patient is small airway asthma, you might consider Foster because of the small airway. But if your patient prefers a medication that has been well tested with robust data, then Symbicort has a lot of data on SMART therapy and been used all over the world with a lot of experience with usage SMART or Symbicort single inhaler.
Okay, and then the next questions will be because we talk about the phenotype and endotype also. And so what kind of tests can we do to check the Th2 or in eosinophil inflammation? Is it a full blood count test?
Okay, I think there's quite a few questions on that actually. So Well, there's many tests we can do. As a respiratory physician, I have a lot of tools on my hand. I have Excel nitric oxide. I can bronchoscope and do biopsy on them, do bronchoalveolar lavage to them, but obviously this is not available. This is not available to the general doctors. So for general doctors, of course, there will be new tests coming out, but at the moment, I think the easy ones that we can do is a full blood count with eosinophil count. If your eosinophil is high and you don't have a worm manifestation, or you make sure that they have a cause of the worm and their eosinophil is still high, then it is one of the markers. This is a Th2 response. You can do IgE. Blood IgE is not very expensive, widely available, and IgE shows you atopy. It may not just be eosinophilia, but atopy. So you have raised IgE, that means you have some atopy inflammation going on, but usually eosinophils are the easiest to use. I think there's a question also on when do you do the eosinophils. If you have an attack and you do the eosinophil, of course it's going to be high. Yeah. So that is a question that a lot of studies are ongoing. And I think from the conference I've attended, basically most of them will do at least one or two when they're well, when the patient is well. At least one or two. And when the eosinophils is persistently high, then you will say they probably have eosinophilic inflammation. Now, eosinophils done during the acute attack is also useful. Because why? If you have high eosinophil during attacks, you know your steroid is going to work. Your oral steroid is going to work. They have eosinophilic exacerbations. So eosinophils, if you really want to see whether they are Th2 response, probably will be done when they are well, when they are quite stable. Then you do a eosinophils. Yeah.
Okay. So another question is talking about using the DPI. So like the patient used after inhalation and they found there's some powder in it. So can we put it back into the device to be inhaled again?
I sometimes I do tell my patient that, but no, if there is powder there, and especially if just one or two times probably okay, but if consistently there's powder left over in the capsule, it means they cannot generate enough inhaled force to do this DPI properly. Therefore, you probably need to reassess them. Nowadays, there's the in-check dial that you can use to assess the inspirational force. So if your patient persistently cannot generate enough force to exhale it at one go, then obviously you are in trouble. Then probably it is not a suitable, or his technique is not correct. It's not a suitable drug for him. Yeah, device for him. Right? Yeah.
Okay. So another question is regarding the COVID-19 vaccine. So is asthma patients suitable to get this type of vaccination?
With the information up to now, with the trials up to now, I think there's no absolute contraindication to COVID-19 for asthma patients unless they have severe allergy reactions. They have severe allergy reactions. So I think asthma patients, we should encourage them to get the COVID-19 and also the influenza vaccination. Don't forget influenza, because I think influenza is, yes, COVID is a problem, but influenza will be a problem also. Yeah.
Okay. And then I saw another question is regarding the use of Hudak device. So will you recommend the patient to inhale twice or more to make sure that all the medication inside are all inhaled?
Again, yeah. You should generate enough inhalation force to get the drug in one go. Okay, if you have to do it a few times, my worry is it's all going to be deposited into the mouth rather than into the airway. So if you have patient one or two times, that's fine. But if you have frequent or your patient consistently cannot generate enough force to inhale one go, obviously there's problem. And also the inhalation force are important because you need to, because it's a dry powder inhaler, they are usually coupled to a fructose or glucose particle, and you need to generate enough force to separate the particle, the drug from the carrier. So if your patient doesn't have enough force, indicated by having to inhale a few times, then I think you have to be very careful about using dry powder inhaler.
Okay. Another question is using of Respimat. So can this inhaler device be used together with a spacer for those elderly that have weak inhalation?
Well, we asked that question to the BI people before, and we do ask them that question, and officially, it is not in their official recommendation. It is not in their recommendation officially, but I know we've all used it. I have certainly used it to the chambers. Just that it is not, they do not have studies. They do not have enough studies to make any recommendation of it at this stage, I think. Yeah.
Okay, doctor. So the next question is regarding phenotypes. So far, how many phenotypes varieties has been identified?
I think I'm no expert in phenotypes, obviously, because this one is really, as you can see, I'll just show you the slide again. What I show you just now and I skip through, basically, is just this is much more simplified already. There's much more information that we know nowadays. But what kind of phenotype, basically, if you look at it, I usually use this slide. Okay. The main ones, you have the Th2 and non-Th2. Why we have this kind of phenotype simply is because they are treatments for Th2. We know they respond to steroid better than the non-Th2. And from that phenotype, you can endotype them because why? Because now we have treatment. We have treatment for IL-5 and we have treatment for IL-4 and there's treatment going to be IL-13 and IL-33. So there is many phenotypes. How many phenotypes? I don't know. I think it's still coming. It's still coming. They're still identifying new phenotypes, new endotypes. But the key is how we're going to use this in clinical setting. And that's where this Th2 becomes very important. Whether they are atopy, they are non-atopy, they're eosinophilic, are they IgE related? The reason is because we have drugs for them and we know they respond to steroids. Yeah. So, and the other thing that I find very useful is this chart, that you know there are patients we have high inflammation, low symptoms, and there are patients with low symptoms, low inflammation, high symptoms. And again, these phenotypes are very important because just imagine you have a patient who don't complain. You thought that their symptoms are well controlled. But if you check their inflammation, look, they're very high inflammation, and you know these kind of patients, you should not, or you will be very careful in titrating down their steroids because their inflammation are still very, very high, even though they don't complain.
Okay, doctor. So we will be answering the last question. So when should be the medication for asthma be stopped? In other words, where we can say that the patient with the bronchial asthma has been achieved remission?
Well, if you look at the latest GINA guideline, let me just go back. Basically, if you look at even the step 1 now. Okay, last time step 1 used to be when necessary. You use. I'll just go back to GINA 2019. Okay, so last time step 1 used to be you just use it as needed short-acting beta-agonist for symptomatic relief. But if you look at the step 1 now, basically it says here controller is recommended. So when can you stop? If you follow the GINA, you should not stop. You should not stop. Even though they don't have much of symptoms, you should still use. But obviously, like I say, most patients will not want to do that. And that's why now the combination reliever and controller are so interesting because once your patient have symptoms and start losing their rescues, they are getting their controller in also. So the question to when should we stop? Going to be very hard. If you want to stop, you have to be very careful. Make sure that they really don't have any inflammation. But basically, if you don't have that kind of abilities to do that, then the GINA guideline is a good guide. You should try to maintain them on low dose inhaled corticosteroids if you can. If compliance is an issue, every time they have an attack, ask them to use something that will combine with steroids so that every time they have an attack, they need to use it, they get their steroids in.
Okay. So once again, thank you, Dr. Wong, for answering those questions posted from our audience. So Dr. Wong, would you like to make a final conclusions, like the key notes for all our audience?
Right. Okay. So basically, I hope today I can convince you that asthma is a disease that involves inflammation and bronchospasm. So patient will have symptoms. Patient will also have inflammation. And by adjusting, by using different types of medication, different devices, you can get it under control. But every patient is different. So you need to have some way of typing your patient. And don't just use one drug, one device. Use various ones that it suits your patient. So spend time with them, find out what the patient wants, check their inhaler techniques, and then if you can, do simple blood tests to check their phenotype or endotype if you can, and then from there choose the most suitable. And the most important for Gina is this: you assess your patient, you make adjustment to your medication, you review their response, and you assess again. So this circle is the key in asthma, that you don't see them and let them go. You follow them up, you adjust, and you review. And that's very important to convey to your patient that they need to come back, they need to follow up. We will adjust, we will reduce the dose of medication if necessary. We will reduce it for you. Yeah. So that would be my final words. See your patient, adjust.
Okay, thank you, Dr. Wong. And also thank you to you, the audience, for attending. So this will conclude our session today. And we hope that all our audience will gain a lot of insight regarding the asthma medication. Yeah. So the topic of our next session will be verified today for a better time tomorrow, where time matters, by Prof. Dr. Chang Sui-Ping, which will start at 12:10 p.m. So stay tuned if you are interested, and have a great day ahead, and goodbye.
Thank you very much.